Hi guys, how are you? Okay, just a couple of things before Dr. Grace is going to start this excellent presentation on how to access premolars. So today we're going to do what? What is our today project? Accessing the anteriors, right? Now, the idea is what? To access three while you hold them on your hands and two mounted, right? Now, if you have not finished selecting teeth for your project, I wouldn't mount any. The idea again is for you to put the teeth like mimicking the oral cavity, right? So make sure that you're gonna select all the teeth for your projects and practicals, especially those that you plan to mount, and then mount them all together. So today, don't worry, you have plenty of time. You can work on extracting, on your hand, like accessing anteriors. If you finish up with your anteriors and you want to go ahead and do the selection of the rest of the teeth with one of our faculty, that's fine, and then do your mounting. Or if you have already done that, you can proceed to the next project. We're very flexible. You can do whatever you want. The thing here is what? Take advantage of the time, of the lab time, and it's enough. I mean, most of 2, 3 hours or 4 hours, sometimes we're not going to have lecture, is enough for all your projects. Just make sure that you have a schedule, keep up with your schedule, check also our syllabus, and then don't worry about the time. It's enough for everything. Questions? Would you like us, that's another idea, to do like a live demonstration? What? Of what? Access. So we were gonna try to do that. Am I gonna promise anything? No. This will be the first time that we're gonna do something like that. But we're gonna give it a try. Okay? And if that works, then we're gonna do the same for all the accesses and the steps for the root canal treatment. Okay? And now, please, Dr. Greaves, I'm sure most of you know Dr. Greaves is our year one endo resident. We are very lucky having him. And he's going to present how you're going to access the premolars. Okay? Do we have any other question as far as the lab and the projects and the mounting and the selection and whatever? It's all clear for you?
So yeah, like Dr. Lilly said, my name is Michael Greaves. Michael's fine, Dr. Greaves is fine, Dr. Michael is fine, whatever y'all are comfortable with is good by me. I used to practice with my brother and my dad. I got tired of getting called little Dr. Greaves, so I decided I'd go by Michael. So yeah, today we're going to talk about accessing the premolar and then a short presentation too on the rubber dam, its usage, why it's important, and why we love them in Endo. So a little bit about me, I get a little, I used to get frustrated when I go to CE and you see all these like pictures of everybody's travel, like the most recent vacation they went on or their beautiful family. That was before I had a beautiful family, so here's my wife and my daughter in the middle there. My daughter just turned 1 on Saturday. Her name is Miriam, we call her Midge. So I did my dental schooling at UMKC in Kansas City, Missouri. I graduated from there in 2017. That kangaroo was drawn by Walt Disney. He's originally from the Kansas City area. Pretty fierce mascot. But after I graduated from UMKC in 2017, I know that a lot of y'all have helped us out in the endo clinic there and have had to hear me drone on about it. But I didn't really know what I wanted to do with did I want to go into private practice? No, I didn't want to do that. But outside of that, I didn't know what I wanted to do. So I knew I had dental school loans, so I joined the National Health Service Corps with my now wife. And we moved to Chambersburg, Pennsylvania, which is that's the town square there up in the center. We worked and practiced there for a little bit over 3 years, and the National Health Service Corps was a huge things. So if anybody's interested in talking about the National Service Corps or what that experience was like for me, I'd be more than happy to chat with you about it. I'm a huge proponent of it. I didn't really know anything about community health center dentistry or anything like that before joining the National Service Corps. And the practice that I was at was great. It wasn't just making amalgams and extractions. It's kind of where I started doing endo and led me on my path to here. After I worked in Pennsylvania, I moved back and was teaching at AT Still for a while from 2020 till this past summer. Also, while I was in Pennsylvania, I joined the Army National Guard as a dentist. So I was in Pennsylvania. I was a dentist for a little over 2,000 infantry soldiers. My day-to-day wasn't really, well, my day-to-day when I was with the Army wasn't really doing dentistry per se, as it was a lot of like triage for like mass casualty events and head and neck trauma, those sorts of things. They just kind of see you as being another medical doctor almost. So that's also a really good experience, a good way to pay off loans and those sorts of things. So again, if you're interested in that, I'd love to chat with you about that too. And then so I kind of fell in love with doing endo when I was working in a community health center. I was doing a lot of internal referrals for endo and for extractions. Another dentist came in like doing extractions, and so I said, you can do the extractions, I'll do the endo. And I thought I should probably learn how to actually do this. So that's why I'm here talking to you all today. When we're interacting in the clinic and those sorts of things, especially in the lab, so when I was at AT Still, a lot of that time, obviously, we had to have masks on everything for COVID. I don't tend to not have a lot of like facial expressions, so if I kind of like stare at you, I may also not be wearing my glasses and I can't see very far. So I'm not like scowling. I'm just looking out over the mask. So I don't have any pictures on here of a cruise. You see a lot of those on CE. I've been on one cruise in my life, but it was a really bad experience. So there was a donut actually that had been on the cruise as well. Just a normal run-of-the-mill round donut. And his goal was to always drive a cruise ship. And so I was talking to this donut while I was on the cruise with him, and he said, Michael, I think I'm gonna get into the cabin there where the captain is driving the ship, and I'm gonna drive a ship. I was like, Donut, you can't do that. And so he said, watch me. So he goes into the cabin, and he starts driving the ship. The ship is going left and right. And the captain had been sleeping. He falls out of his bed. He's like, what the heck? He comes in and he sees a donut driving the cruise ship. And he's like, Donut, what are you doing in here? And the donut said, well, this is my life's dream to drive this cruise ship. So he said, you can't get in. You can't come in here. Don't come in here again. So the donut, leaves. A couple days later, he's got that itch again. He really wants to drive this cruise ship. And so he tells me, he's like, Michael, I'm going to go for it again. And I said, Donut, I don't think that's a good idea. And but anyway, he snuck back into the cabin and he's driving the cruise ship. And the cruise ship is going all over the place. Captain falls out of bed. He's like, it's that darn donut again. I'm going to be frustrated. The captain goes in, sees that it's a donut driving the cruise ship. And he says, Donut, I'm sorry, but I'm responsible for thousands of lives on this ship. This ship costs $1 billion. I can't have you driving the cruise ship. We can do a simulator, something like that, but you can't be driving it. If I see you in here again, I'm just going to throw you off the ship. I don't care if we're at port or where we're at, but I'm going to throw you off. So the last day out at sea, the donut comes up to me. He's like, Michael, I don't think that the captain's actually going to throw me off the ship at sea, and kill me like that. So he said, I'm going to try it one more time. And so he goes in to the cabin and starts driving the cruise ship the third time. Captain falls out of bed and he's like, I have to throw that donut off the ship. So the captain goes into the cabin and he sees the donut in there and he just throws the donut off the ship. So we are going to talk here about access, particularly for premolars. So Bertucci came up with his classifications here. Knowing the numbers of them is not super important for you all as much as it is knowing that, looking at it from that one PA or possibly even two PAs is not going to, be just maybe a straight single canal. There could be a lot more going on in that anatomy. So that would be, I know Dr. Lilly talks with y'all a lot, and we'll talk a lot about taking two PAs, but using those two PAs from different angles can kind of help show you, what's going on inside the tooth there. So proper access, like we talked last week about, gives you adequate and safe cleaning, shaping, disinfecting, and obturation of the root canal system, and also in making sure to retain the tooth structure, because obviously that's the goal, is to restore the tooth. Again, we kind of looked at this last week a little bit too, but just to kind of review. So, we definitely want to locate all the canals. Gonna make sure through our access that it's going to allow us to have nice cleaning and disinfection of that root canal system, and then filling of the root canal system, and then again preserving enough tooth structure so that there's long-term survival of the tooth. You all seen this picture here, and again, just kind of looking at our access preparation. We definitely want to remove all the caries when they're present, and any defective restorations. Removing the defective restoration and the caries is going to show you how much tooth structure is left, of course, to determine, is this tooth restorable? How am I going to have to restore the tooth if it is restorable? The only time that you may not do that is, if you're trying to, say, if like the distal of a second, the most posterior tooth or something, you may kind of preserve that little bit of on the distal or some of your walls to be able to, make sure that you have proper isolation when irrigating, and it makes it a little bit easier with the sodium hypochlorite, but that's kind of limited cases. And of course, we talked about Krasner and Rankow last week, so this of course comes into play with the premolars here, when looking at the how you're going to find those canals. So this picture is good at kind of showing the law of concentricity here. So you can kind of see how this dips in here at the CEJ, and the pulp chamber does as well. And we kind of see that these two canals are parallel with each other. So you can kind of take your, I recommend taking your explorer, your probe around the tooth to kind of feel that anatomy, particularly on the maxillary first premolar, which we'll talk about. Again, we talked about that symmetry on there. And then the color change, so the pulp chamber floor is going to be darker than the walls as well. So you kind of, here you can kind of see this map of where we would expect the canals to be, even if they weren't accessed, just because of that color. Using that endodontic explorer is important too, a nice sharp one. So I know that, you're going to want to reach for just your normal explorer, but using the endodontic explorer is much more effective and efficient. Again, having been practiced as a general dentist for about 7 years, having extra instruments can be expensive, and it can be tough to have your assistants, kind of put together and flip rooms for you for different procedures. But having the right instruments, is important. So if you're not getting a stick in the tooth, of course you haven't found the orifice. Like this Endo Explorer here hasn't quite made it to the orifice into the pulp chamber there, so we know that we're not quite in it. And again, you guys saw this picture last week on the straight line access. So looking at premolars specifically, real big thing with them is the mesial concavity on those premolars, particularly the maxillary first premolar. When I was doing my board, we had to do it on actual teeth, just not live patients. I couldn't, as you all experienced, how hard it is to try to find good teeth, when you're x-raying them. I couldn't find any molars, so I thought, I'll do a maxillary premolar. That's easy. It's got 2 roots, and access is just an oval, so I'll be fine. And almost perforated out the mesial, so everything worked out, obviously, but that mesial concavity can really trip you up sometimes. So looking at the maxillary premolars, so the first and second premolars typically have a pretty similar outline for your access, and that's going to be kind of an ovoid form access from in the buccal and lingual dimension there. And then here, obviously, you can they kind of appreciate that mesial concavity. So as you're accessing the tooth, if you're off by just a couple of degrees to the mesial, then you could potentially come right out that concavity there. So for the maxillary premolars, obviously, as you all know, most of the time they're going to have 2 canals, and most of the time the second maxillary premolar is going to have 1 canal. There can be variances from that, but that's what you're going to be looking for. So taking those 2 PAs to kind of shift and make sure that what you expect to be there is actually there, and confirming that is important.
How did that one end it like this? The right one. Really? It should be rotated.
It should be rotated.
Anyway.
So, the first premolar erupts typically between 10 to 11 years. Obviously boys, males can be a little bit behind that. And on average, they're about 20.6 millimeters long. Most of the time, the buccal root is going to curve to the lingual, and most of the time, the palatal root is going to be pretty straight. You guys will also learn that pretty well, not only from endo, but extracting maxillary first premolars, how frustrating those little root tips can be. When both canals are present, typically those canals are kind of right underneath the cusp tips, as you can kind of appreciate in this photo here. If there's 3 canals present, you're going to have a triangular access, but that'll probably be more in kind of the endodontist realm there. So, kind of looking at the anatomy here of this premolar, I know that you guys have probably taken morphology and those sorts of things, but the furcation is typically pretty low, and we would expect that the pulp horns are going to be, and the orifices are going to be pretty much right underneath these cusp tips there. Looking at the maxillary second premolars, they're going to be a little bit longer on average, 21.5 millimeters, come in about the same time. They can have 1 or 2 canals. Typically, the root is going to kind of curve to the distal, like a lot of other teeth in the mouth. We're going to have that same kind of oval access, and then you can kind of see how how the pulp horns and the pulp chamber kind of situates itself underneath the cusps there. Oftentimes, you're going to find if there are 2 canals, whether it's in a first or second premolar or whatever, there's going to be this kind of isthmus here. Depending on the case, if that isthmus is present, you'll want to open it up, but what you want to be careful of is not, kind of creating your own. That is then going to be, that is going to cause damage to the tooth. So if it's there, you kind of want to take it so that you can open things up and make sure that there's no extra anatomy in there. But you don't want to just kind of go digging just because you assume that there's going to be some sort of isthmus there. So looking at the mandibular premolars, so again, they kind of erupt in a similar time as the maxillary teeth and are about the same length. And most often they're either going to be straight or curved to the distal. Knowing where they curve is obviously important, just so you can know how to maybe pre-bend your file when you're going into the tooth, so that you can, you know it's not going to be straight down. So if you're just sticking a straight file into a tooth, what could happen is you're going to, get to about here or so, and then kind of start to create a ledge, and then now you're in trouble. So, kind of pre-curving your files is a nice way to make sure that you're kind of sliding down this canal, the anatomy that's there, as opposed to kind of just being a tooth mold burrowing through the tooth itself. So, the difference between these mandibular and maxillary teeth, so the mandibular teeth are going to have this really prominent buccal cusp, with a little bit, smaller of a lingual cusp here. So, that's also going to kind of throw off the orientation of the crown when you're accessing. Most of the first premolars are going to have 1 canal, then a large majority of the second premolars are also going to have 1 canal. As I mentioned, with that buccal cusp tip being so prominent and situated a little bit lingual, pretty much kind of right over the center of the canal. Your access is still going to be ovoid, and it's going to be
just make sure that it's centered. Let's begin. Remember what we said? All your accesses at this point should start in the center. Okay?
So, visual representation. Hopefully you guys are more into pictures than words. So, here, is how...
I'm sorry, if you can go back. I'm sorry, that's a great interruption. So generally, I think this should be said exactly the opposite. I don't know why it said backally. It should be backally, lingually to the central groove. The lowers, the orifices, is usually more lingual than backal. Okay?
So, again, remembering that that crown is going to kind of have that lingual inclination. And so the pulp chamber and the canals will kind of also follow that too. What you want to be wary of is, again, that you're not just saying like, oh, I'm going for the center because it's a premolar, and drilling straight down. Obviously want to kind of have a little bit of a buckle inclination to that, but you also want to make sure that you're not leaving any part of the pulp chamber that's left unroofed. So this is where tissue and caries and those sorts of things can hide out and cause you to be unsuccessful. So making sure that you've got that kind of straight line access and cleaning this here is going to be important. So that's for the premolars there. We'll chat about rubber dams here, Dr. Lilly.
Okay, one more thing, and just to remind you, and you're gonna hear me say that again and again and again, for anteriors and premolars, upper lowers, start your axis in the center. Number one. Number two, don't go mesial distally. There is nothing there. If there is another canal, it should be either palatally, if you have buccal palatally or buccal lingually. Mesial distally, remember, is the smallest diameter, and if you extend your axis either mesial or distally, you are gonna end up what? Creating a hole, perforating. So don't go mesial distally on any anterior or any premolar. Stay in the center and extend buccal palatally. Okay? And always try, take your time when you're accessing, and if you can go back, and just make sure always your burr follows the inclination of the crown. You see what I'm saying? Because the crowns are never like straight vertical. So just make sure that you tilt your burr and follow, be parallel to that long axis of the crown. Okay? So center, parallel, never mesial distally for anteriors, upper lowers, premolars, upper lowers. Okay? I'm sorry, Dr.
No, that's great. And if you have any question about it, it's super easy to just stop and take an X-ray. So take a bite wing if you can to kind of see, where you're going on track, or PA if you need to, if the bite wing's not available. Especially when you're practicing, you're going to be looking for those kind of out moments of time that, you need to go do a hygiene check, or you need to go prep something else, or get someone numb or whatever, and your support staff are going to be telling you that they need you in another room. So if you're feeling like you're stuck somewhere, just stop and take an X-ray, and of course you're going to lie to the patient and say everything's going well, and that you're just going to check on things and make sure that everything's going well. But yeah, it never hurts to stop and take those X-rays. Where you get into trouble is when you kind of start to do things too quickly. So going slow is smooth, and being smooth actually makes you fast. So. Here we'll have a little quick thing on rubber dam. So again, I don't really have any pictures of any vacations from this one, but I did go on a beach vacation one time, and while I was on this beach vacation, I saw this billionaire that was pretty popular guy. You've probably seen him in the news a lot. And I had heard this story previously, some rumblings, and apparently this billionaire, he was about 50, he'd been trying to find love his whole life, but he'd always been super rich, so he thought, oh, maybe everybody's after me for my money instead of loving me. So what he did is he went and got on Tinder, he made a fake profile, everything was true about him except for his name and his face. He found this gal that they kind of fell in love over the internet. They started chatting for a while, and he thought, maybe this is the one. So he went to New York, and he had a custom ring made. It took several months. They had to go get the diamonds dug up out of the soil and everything custom fabricated. And so he had this ring made, and he said, hey, this is actually who I am. I know that that's a lie, but I'm going to be sending a private jet, and then I'm going to take you to this kind of beach destination getaway. So he picked her up, and she was a little kind of off-put, obviously, because she thought she fell in love with someone else, even though everything about him was the same except for his $1 billion. So there, he had this whole week-long thing planned, and he's nervous. I don't know if any of y'all have proposed to a spouse or anything like that, but you hope their answer is yes, but you're never quite sure. So he had this ring in his pocket, throughout the whole week, and he kept on thinking about popping the question, and finally they were there for the last day, and they're walking, and she sees that he's got this nice table set up with a nice waiter and black suit and white tie and everything like that. She's just kind of overcome with emotion, and she's like, "Hey, come swim with me," like that famous scene from the old movie where they're like rolling around in the sand. And he's trying to push it off, but she convinces him to come out there. And when they get out of the water, he realizes that the ring is gone, and he's like, "Shoot!" So now he's upset. They're going to dinner. She's kind of getting over it, but she's reading that he's a little upset, and she doesn't know why. So they're sitting at this really nice dinner. The waiter comes up, and he's like, "Hey, can I get y'all anything to drink?" The waiter, of course, was in on that he was going to pop the question. So they said, "Yeah, we'll take some champagne, and then we'll also take some appetizers." So the waiter comes back. The guy is still really dejected. The woman is starting to get more and more upset because she doesn't know what's going on and why he's so upset. Everything was seeming like it was so great, and she thought that he was going to pop the question. So the waiter brings out the champagne, and he brings out the appetizer, which was oysters. And so shuck your own oysters. I don't know if y'all ever done that, but they set them out. She goes to shuck her first oyster, and do you know what she finds in the oyster? What's that? No, she finds the donut. All right, feel free to use that for your patients.
Come on now.
Pain-free endodontics.
I thought she found a pearl or something, right?
So this is our rubber dam here. How you guys feel now is how your patients feel sitting behind this rubber dam.
So wait, go back. I'm sorry. If I see something like this, we're gonna fail the lamp. Why? Why are we putting? He's gonna tell you. Protection, patient protection. He's not gonna swallow anything, basically, or any of your. So you have hypochlorite. Remember, never we say the word bleach, but actually that's what it is. So you don't want your patient to swallow. So this is exposed. The lips are exposed. The cavity is open. Everything can drop there. So please try to practice even starting now from the lab, because you're gonna use that and use it as much as you can on the mounted teeth, of course. You're gonna put it in the finger when you're holding the tooth. But please make sure and ask us how to do it correctly. Okay, this is very important. I'm sorry.
Yeah. So, I'm sure that you all probably saw when you were doing your shadowing, getting into dental school and such, or maybe if you've worked at a dental office or a family that are dentists, most are probably not using rubber dams frequently for operative and those sorts of things. You know, UMKC was the same way that SIU was. We didn't really often have assistants, and we had to have rubber dams for everything. That's kind of when Isovacs were first coming out. So if it was like the distal of the most posterior tooth for restoration, we could use the Isovac. But outside of that, we were kind of stuck using rubber dams, and I hated it until I got out and realized that I was fast with rubber dam and efficient, and kind of wasn't. I kind of had those reps in on it. So again, as frustrating as it can be to use the rubber dam, it is. This is the time to get used to it, because I guarantee that when you get into practice, you're not going to take the time to learn how to use the rubber dam effectively. And so, it's kind of like when you have the rubber dam on appropriately, it really, when you're working in a patient, kind of takes you back to working on a mannequin, because things can, you're just kind of zeroed in on that tooth, that quadrant, whatever you're working on. You don't have to be fighting, you're not fighting a ton, and those sorts of things. So, obviously some issues with these radiographs here is that there's no rubber dam. So, we're not protecting the canal and the inside of the tooth from, the bacteria and the saliva and the, fungi and all those sorts of things that live in our mouths. But we're also not protecting the patient from things dropping down their throats, the medicaments that we're irrigating the tooth with. So I kind of explain it to patients both ways, but typically what I hit more on is that, that their tooth is going to be behind the rubber, or they're going to be behind the rubber dam. The tooth's going to be out. So, they're not going to have to worry about having a whole bunch of water that, is just going to make them feel like they're drowning. So they're not going to have to worry about tasting anything that you're using, because those oftentimes are patients' big issues, is that they feel like they're drowning. They're tasting stuff that's disgusting. So if you can kind of let them know that they're not going to be experiencing that, my experience has been that they could care less whether or not, or they couldn't care less whether or not there's bacteria getting inside of the tooth. What they want to know about is how it's going to improve their experience. So, I let them know it's going to be a little bit of a mouthful going in, but once they get situated, they're going to be able to swallow. They're going to be able to breathe, and it can kind of make them feel like they're back here and you're working on a tooth over there, and it kind of creates that barrier between you and the procedure, and them. So again, yeah, obviously, gives protection for the patient, creates an aseptic environment. It enhances vision because again, you're not fighting the tongue, saliva, blood, the cheek, all those sorts of things. It retracts all that tissue for you, and so you end up being more efficient. So yeah, it takes a couple minutes to put on, but once you have it on, you're saving that time for you. And if when you get into practice, something that I like to do is training your assistants on things like placing a rubber dam so that you can get the patient numb, you can go do your hygiene check or your other prep or whatever it may be, and come back when that rubber dam's on and you're ready to go and you can kind of start the procedure. So it is mandatory for legal considerations. The AAE, has been very clear about this being the standard of care. Only in a few recent studies, though, only about 60% of dentists who are doing molar root canals are using rubber dams for that, and that's kind of across the board for general dentists. So even though it is the standard of care, this is something that gets kind of left behind a lot. Isovacs and isolites, those sorts of things will tell you that they're providing the same kind of aseptic environment, that they're protecting the patient, but that's all their own research. We know that rubber dam works. I had a patient yesterday actually that the guardian was concerned because after their previous appointment for some crown lengthening, they had been having like a dry cough for a long time, and the guardian was concerned that it was because of the dental treatment. And I kind of had a discussion with her that the patient possibly could have aspirated some tissue or something from the treatment. But that wasn't going to be a concern for us because we were going to be using rubber dam, and it makes you more confident when you're placing your sodium hypochlorite, or whatever material, because you know that if your rubber dam is on appropriately, there's nowhere for that to leak kind of into the mouth. Of course, we need to protect the patient from aspirating or swallowing anything, and then we found especially big during COVID, was that prevents the aerosols from coming up into your face. Like a lot of y'all wear like ear protection and that kind of stuff because the mouth is gross. And then we know that there's a decreased success rate when it's not used. So, like I said, it is the standard of care. If you don't use it, you are putting yourself out there to be sued. So the rubber dam here is going to come in this kit. So we've got the punch here, the forceps, the frame, and then the clamps here. Typically we've got this kind of as being an anterior clamp here, and then a couple premolar clamps, a few premolar clamps. A lot of times these are used for molars, and you can kind of use the clamps however you need to be able to make the rubber dam fit. It's not like a recipe book where you have to do X, Y, or Z, or step 1, 2, or 3. If you're doing tooth number 7, you can use a premolar clamp to isolate from 5 over. We'll talk about a few different methods for clamping. So obviously you've got the wing clamp and the wingless clamp. Depending on the space that you have available, I like to use the wing clamp most of the time. I just find that it's a little bit sturdier. It would also not really let dental school ruin your rubber dam experience. Most of the clamps you're using have been used autoclaved, thousands of times, and the rubber dams are cheap. So, when you get into practice, if you have nice clamps and nice rubber dams, they're not going to tear on you and rip, and the clamps aren't going to pop off all the time and scare you because they haven't been stretched out a bunch. So like I said, we've got a frame here. This frame we often use for endo as opposed to this one. Anybody know why? Yeah, there, yeah. So, this is going to show up on your radiograph. And then, various sizes of rubber dams. This is Dr. Lily's favorite. So, originally they were manufactured from latex, but now ours are non-latex, to avoid any allergies. Like I mentioned, they come in various colors and thicknesses. You can kind of decide what is best in your hands. Everybody likes a little bit different of one. Obviously, if it's a little bit lighter, it's going to get a little bit stretchier, but it's going to tear a little bit easier. Versus the heavy ones will be a little bit more durable, but sometimes a little bit harder to maneuver.
Two sizes. Also, they're coming into two sizes. Two, right? Only two.
Yep.
You don't want to use the small one. I don't know. Maybe you use that in Endo. I don't know, but not for us. Not for endo. Whenever you're doing endo or any vital part or whatever you're gonna do, we prefer unless you have a very tiny patient with a very small, face and mouth. That's fine because you don't want to cover the whole face. So like you want your patient to be able to breathe, right? So, but most of the times, just use the big size, the big size.
No, do they have those?
Oh, 6 by 6.
Do they have those rubber dams with like the white paint around them that is like all in one?
No.
Okay. So they make these rubber dams that you may have seen them. That then they have like a I don't know if it's plastic or what it is around the outside, but it's supposed to act as frame rubber dam in one. I found they're okay for anteriors, but it can never get into work for posteriors. So much to go back there. Using the traditional rubber dam in the frame is much better. So it's also best to kind of ignore the template holes on the teeth. Instead, you're going to kind of punch your hole into the quadrant that you're in. These are a little bit too specific, and you don't need that to be successful. You can switch this up again for a little bit, though. Like I mentioned, there's no recipe book, so I had a patient with COPD and asthma and all these issues, and sleep apnea, and he couldn't breathe really well. So we were working on number 2, but I ended up punching over here, and the whole dam just kind of shifted over, so that he had, as Dr. Lilly mentioned, that area to breathe. You'll want to trim after you get it placed. You may want to trim the top of the dam to make sure that it's not tickling the patient's nose or overlaying their nose. If you don't want to trim it, if it's overlaying their nose, you can just put a piece of cotton there. That cotton will provide space as well for their nose. So there's a whole slew of ways you can place the rubber dam on the teeth. Kind of found that placing it as a single unit is most efficient and most effective. So that's what they're preparing for in this picture. So the rubber dam goes up over the wings while you're placing it, and then after placing it, you can use your explorer or condenser, whatever you got, to kind of push it down up underneath the wings, and that'll kind of let everything kind of hug around the tooth. You can also place the clamp and the rubber dam and then attach the frame on there. It's similar to this whole single unit, but the benefit of using a single unit is that you're not getting like saliva all over the place. What I found with doing the clamp and the rubber dam together is that saliva gets all over the place, and then you're trying to like hold the rubber dam back, and your assistant's trying to help you. Things are kind of falling all over the hole that you're trying to look through here to make sure that you're putting it on the right tooth. Placement of the clamp, and then the dam, and then the frame. We use this a lot for like the most posterior tooth. Sometimes if some of like the muscles are in the way, when the patient's opening wide, or if the ramus of the mandible is in the way, sometimes placing that clamp first and then stretching the dam over it is a little easier. And then if you've never seen anybody do So really important is to make sure that you've got floss ligated around the rubber dam clamp, so that if it goes where you want it, where you don't want it to, you can easily retrieve it. And then that floss could just kind of go up underneath the rubber dam, so it's not in your way at all. So this is kind of everything at the same time, that preferred method that we chatted about there. So you can see that you're kind of easily going to be able to see the tooth through this hole, and everything's going to go on at once. If you leave, you can kind of see how this is a little loose here on the rubber dam, or the rubber dam is a little loose on the frame. That allows it to stretch a little bit more, because the frame is, and the rubber dam is going to rub up against the patient's lips, and then this will kind of stretch back. If you have everything too taut, you're going to be putting too much pressure on the patient's lips and mouth and cheeks and those sorts of things, and it's going to be uncomfortable. So this is the other method. This is a method that we talked about clamping the tooth first, and then stretching over the rubber dam, or the rubber dam over the clamp, excuse me. The nice thing about this is that obviously what tooth is going on easily, because you can see the other teeth around it. It's not bad practice to somehow make like a mark on the tooth if there's not something obvious about the tooth. If you're doing your premolars, make a mark to know that I've got my little dot on the buckle here, and I can see that dot on the buckle of my only tooth that's sticking up through this, so I know I'm working on the right tooth. The downside that I've found to this is that A, the clamp will pop off a lot, and B, the rubber dam will tear a lot too. So as you're trying to stretch it over, and where the rubber dam tears the most with this method is in the anterior, with that kind of big old clamp that's on the right here. So trying to get the rubber dam to stretch over this thing is quite difficult, and it will often tear.
And if you decide you have the just with all that, if you are gonna use this type of way of placing the clamp, and again in the lab you're gonna experience, you can do all the ways. But if you decide that you prefer this one, just make sure that you always put a floss in the clamp, on the clamp. Just tie a floss, right? And you know why. If it jumps, then it's not gonna go into your patient's throat. You can pull it out, okay? Something that you don't have to do when you put it all together.
And obviously, ideally, this clamp is going around, like the CEJ, but there may be times that the tooth, is quite a bit broken down, or the caries is in, a little bit more gingival portion, the gingival third. You may need to put that clamp on the tissue itself. It's not going to cause any issues. The patient's numb, so they're not going to know or care. I just let them know afterwards that that clamp was on the tissue to hold everything on. They may kind of feel like they had like a little vampire bite there or something. That's normal. What can happen in the maxillary posterior area specifically is sometimes that area may like necrose a little bit. It can also happen from like your anesthetic from your palatal injection. But when you call and follow up with the patient, it's nice to just kind of, if they express that, you've already told them ahead of time that they may experience that discomfort on their tissue. So yeah, this is for the anterior here. So this is before placing, so you can see how the rubber dam is going over those wings, and then after placing, and then what we do next, we go in and floss this to make sure that it's all done. Oh, sorry. Yeah.
Oh, it's okay. Does clamping the tooth you're accessing ever affect you taking the x-rays? In the way?
No. So, I mean, well, as long as your x-ray is not like foreshortened or whatever. So, if you're going to take a bite wing, I guess, that would be the risk. So if you're trying to determine restorability, I would clamp behind it, or I would wait to clamp until you know that you're going to go in and do the endo. But once you're doing the root canal procedure, as long as you're not foreshortened and your apical region is being cut off by the wings under the clamp, if you want to be efficient with your time and you're working on a premolar, and you want to make sure it's restorable, then I would just throw a tooth behind and clamp it. see all these cool people on Instagram or whatever that have like 8 teeth isolated in their mouth, and in endo it's not really necessary unless you're looking to do a sore or something.
With this clamp, just please pay attention to this picture, right? The high part, the highest part of the wings looks palatally or lingually, not buccally. Okay? That's something I see all the time. I don't know why. Sometimes confusing. So make sure that the high is palatally or lingually between the lower one.
So this here is called Orasil. You can also use Cabot for this. So what this is doing is, even though you may have a nice tight seal, sometimes, especially on a lower tooth in the posterior, the saliva can kind of bubble up underneath there, or vice versa with what you're spraying. So by placing the Orasil around the tooth, that prevents any seepage of anything. Orasil is nice because you can kind of condense it and pack it, and it stays a pretty similar consistency. Whereas the Cabot kind of, can get a little crumbly or dry out a little bit. The Cabot's cheaper, and if you're a general dentist who may have more Cabot laying around, you use a little Orasil. So you can just kind of roll the Cabot up like a little hot dog and place it.
Just like a donut.
Yeah, you feel like doing it around. So you can use wedgets, in difficult anatomical cases, if there's weird crowding, something like that, or sometimes in the anterior, if you're looking to isolate multiple teeth, or if it's like a young person and their dentition's not fully formed yet, the height of contour on the tooth may still be a little bit kind of covered up by the gingiva. So sometimes what's a little bit easier is to just kind of place those wedgettes on the furthest aspects of the rubber dam from the tooth that you're working on. Um, the trouble with this sometimes is that it can be a little bit more open to leaching because that clamp isn't pushing down on it, and you want to make sure that it's stable too, because you're going to have to move this rubber dam to take radiographs and those sorts of things, suction behind it, etc. Okay, so this is just some lab stuff.
Yeah, so if you go back, so for your access project to be done and swiped by a faculty, you must finish all five. Okay, once you're done with all five, 302 mounted, then you can ask us just to swipe your code. Okay, and for the rubber dam, just keep in mind the dam is out once you're done with your root canal treatment. Once you place your temporary restoration, you can take it out, not before. You can access, you can start accessing any tooth, maybe without a rubber dam, it's fine. Well, if you're asking personally me, it's not fine, but that's something that, it's acceptable. But once you start using instruments like the Endo Explorer to find out where the orifice is or files, you should have your dam on. Okay? You would have any questions. And we're going to show you what's the best way, to punch holes and